Okay, so thank you very much for inviting me to open this new series of MRC Seminar. I'm very honored. I feel I have a lot of responsibility, first of all, for testing now the technology and to deliver something that is worth listening to, given the delay that we started doing. I work at the MRC Biostatistics Unit, have a long-standing collaboration with Public Health England as well. At the MRC Biostatistics Unit, we have a number of projects ongoing on COVID, and what I'm going to present to you today is the one that I've been involved most directly, and is the one that in a way has been most visible. It is about tracking the COVID-19 pandemic in real time. I'm going the talk, hopefully in 20 minutes, will be about this. This is the outline. I'll give you a little bit of a background to the project in itself, a little bit of an insight into the methodology, the model that we use, the available data, the outputs that we produced, and their role in the first pandemic wave. Then I'll mention a little bit of what's going on at the moment, the current situation, the challenges, and hopefully I'll have some time for some questions. Next slide, please. Okay, so a little bit of a history about this project. Was initially funded by NIHR after the H1N1 pandemic over 2012 and 2015. Was a part of a series of a portfolio for pandemic influenza preparedness. And the idea is that if funds were being made available to prepare somehow for the next pandemic, then we'll be in the next pandemic in place, in the right place to be promptly using our methods and our study designs. So this was one of these projects, and the idea is they will be set up, piloted, and hibernated for a while, and then promptly activated in the event of a new pandemic. And the idea was to support the pandemic response in real time. This was initially, as I said, funded like this, and then has been further developed through continual MRC funding since 2015. Next slide, please. Okay, so what is this project about? It's about pandemic nowcasting and forecasting in real time. What does this mean? I don't know the audience out there, so I would like to make clear the terms that I'm using. So nowcasting is about estimating the current state of an epidemic. So the level of disease transmission that is ongoing, and one of the measures is the now famous reproduction number R, estimated the number of new infections that are occurring, and then the proportion of the population already infected. Do you know that all of these things are not observed, so they need to be estimated? This is now, current state. Forecasting is more about predicting what is going to happen. So predicting level quantities, perhaps the demand of the health system in terms of hospitalization, or perhaps in terms of death. And all of this in real time. In real time doesn't mean immediately, but it means as data become available sequentially, the idea is to provide an update, a regular update of these two aspects of the epidemic. Where are we now? Where are we going? And this was in close collaboration with Public Health England. Next slide, please. And this is a number of papers that we produced after the H1N1 pandemic, showing a little bit of the progress that we've done in terms of methodology. And the last one on the bottom right is one of the papers that we produce, applying these models to the to the seasonal influenza. We're talking about influenza because we thought that the next pandemic will be an influenza pandemic. So this is what we published in the past. Next slide, please. And this is the model. Now I'm trying to give you an intuition of what we are doing. I don't know how many of you know about transmission models, compartmental models, SIR type models, but I'm assuming that you know a little bit, but if not, I'll explain a little bit. So we have what we call age structure and transmission model. At the top, we have what is called, in short, SEIR model that governs the transmission of the disease. The idea is the population can be subdivided into different groups, susceptible, and SAT here it denotes the susceptible population, a particular age group, for instance. Then they become exposed to the infection, they become infected or infectious, and they maybe recover, they die or they recover. So this is the stratification of the population, either in susceptible, in exposed, infectious, and recurrent. Thank you for using the mouse. I realize that I cannot do it myself. Thanks. So in all of this, what is really tremendously important, obviously, is to try to understand the transition from being susceptible to be exposed and infected. Now, we don't observe this. You know that we do not see the number of people being infected with COVID, for instance, and we don't see people being infected. At most, we can measure the number of people infected. So the aim of all of this modeling is to estimate the transition from susceptibility to infection. So the number of new infections. And this number of new infections, which might be different in different age groups, and definitely the pattern of this infection changes over time, is a function, is expressed in terms of a number of things. It will depend on how people interact, how often, and how they interact. And you've learned a lot about this during this COVID epidemic through all we've learned about the social distances and how the social distances can be used to reduce infections. So the idea is to estimate these things, which I've, from a mathematical point of view, indicating as lambda. And this is a function of the interaction between those who are still susceptible and those who are infectious. So it's a function of that's why there is this arrow at the top. Now, as I said, direct information is very rare. What we see is what emerges. For instance, people have symptoms and they are confirmed, or they go to the doctor. And this is what we had in terms of H1N1 pandemic, or the idea that the model that we use then. We use people confirmed, people going to the GP, although the signal about the epidemic or the pandemic in the GP data is very noisy, because, for instance, in this case, for the H1N1, people were going to the GP for a number of reasons. The symptoms were not specific enough, and so the number of individuals going to the GP was not a solid, a very clear signal of the progression of the pandemic. So we had to use additional data on virological positivity, so whether people were carrying the virus, to be able to extract the signal. But in any case, the case confirmation, the data on the GP consultation, together with some virological information, and seroprevalence data here, which is the most direct information on the immunity or the susceptibility of the population. These were cross-sectional surveys, very much like what's happening now for COVID, which will give information on the level of antibodies in the population, and therefore directly informing the portion still susceptible to the disease. So a combination of data sets, which all together, put together, are able to enable us to estimate the number of people going from susceptible to infected. For those who are more technically oriented, I can tell you that this was a Bayesian model, and we estimated the parameters in this lambda, all the quantities which are relevant and are related to the development or the transmission of the disease through random walk metropolis testings. Anyway, let's move on. Now for COVID, we also did have a choice of different data sources. We have confirmed cases, and at the beginning, we know that, particularly at the beginning, it was difficult to interpret the meaning of these numbers due to changing policy on testing, and there was an inconsistent ascertainment. So the use of this data was quite challenging. Not that now is much easier, but I'll come back to that. There was hospital information on hospital admission, ICU admissions. Again, these were soft in a way data because they were subject to change admission policies, and they're still unclear exactly how they could be interpreted. Equally for hospital bed occupancies. Then we had data on deaths, so the people dying, whose death was related to COVID. This was the clearest signal because it's a solid signal, death, but it's quite lagged because from infection to death, there is an interval of roughly 2.5 weeks. So someone who's dying now is an infection 2 or 3 weeks in the past. So it's not really a contemporaneous piece of information, yet it is very solid, it's very reliable. Then there was serology, like for the H1N1, serology informing antibody level in the population at different point in time. Again, this is a little bit lag because it takes time for people to develop antibodies. Please, next. And so we decided the most reliable data were the dense and the serological data. Next. Although at the moment we are using the data from the pillars, you know, I assume you know about. I'll come back to that. Okay, so the models, the structure of the model changed a little bit. It's much simpler structure. Again, you've got your susceptible, exposed, which is in 2 different classes to make the model more flexible. The infectious, again, in 2 classes, so the model is more flexible, and the parameters or the unknown quantities which are really defining this new infection lambda are informed by the seroprevalence data from blood donors and from lab confirmed deaths over time. So we have data time series over time. I'll come to that in a minute. This is therefore is an age and region specific model. You can see there as a number of regions. These are the NHS regions. And the idea, again, is to use this data to estimate the parameters in a Bayesian framework. Please. Okay, so this model was used consistently throughout the pandemic. So in the pre-lockdown, during the lockdown, and in the period where the lockdown was slowly eased, to anticipate the impact of the lockdown, to provide the real-time updates of pandemic dynamics, for instance, the estimation of the R, and to inform the lockdown relaxation. And then this was to contributing in this way to the SPI-M consensus for SAGE and the consequent pandemic management. Let's see examples of its use. Pre-lockdown period in March. the question was what level of social distancing would be necessary to suppress transmission. I remember this was exercise we did around about the 20th of March. There was very little data to use, and so we couldn't really use the old structure of the model. We couldn't use the age structure, and the numbers in each regions were so little that the only regional stratification we could use was London outside London. Please. So we consider a very simple model. We looked at 3 scenarios for the overall reduction in transmission: 24%, 48%, 64%. And when I say that, I relate to the metrics of interaction between susceptible and infectious, which was simplified here to much simpler structure because we didn't have the age information. Please. These are scenarios that we produce after fitting the model, so estimating the parameters of the model using the limited data that was available at that time, and projecting forward. The results are referring to the rate per 100,000 per day, and the top row refers to the infections, and the bottom to the deaths. Just let me go through a couple of examples. I mean, there was the results in terms of infections per day in either London or outside London. You can see that these were sort of predictions from our model. The solid line represent the central prediction, and the shaded area represent the possible the envelope of possible results. And you can see that, for instance, in London, outside London, I mean, the things are shifted a little bit, but the sort of central value, the central estimate seems to be highest at a level of typically 2,000, just over 2,000 infections per 100,000 per day per 100,000. So if you do some little multiplications, so 2,000 by 10 by 60, you can imagine that the number of infections that we were predicted to would be observed, and this is the central estimate, not even the higher possible limit, was of the order of 1 million a day, 1,200,000. So this wouldn't really resolve the problem. On the other hand, if you look at the 64% reduction in transmission, that is much lower, but this kind of values of 2,000 per 100,000 per day was still possible. The number of deaths, if you look at the 24%, you can still talking about 20 per 100,000 per day, which a little calculation gives you 12,000 deaths per day. Again, much reduced, but not really within any reason with the 64% reduction in transmission. So please, next. So the bottom line of all of this, then in both London and outside London, to be 95% of the RTDR was less than 1. And we know now that less than 1 means reduced transmission or non-ongoing transmission. We needed to come to reduce the interaction between people by at least 81%. So this is almost very close to the lockdown that was operating in the end. Please, next. Okay, so that was an example of how we used this model to understand the effect of a possible lockdown or some sort of restriction in social interaction. Then after that, in the in the after March, in April and May, obviously data started to accumulate. And we can see on the right-hand side a profile of the number of deaths in different regions. These are the NHS regions. And you can see that the number of deaths peaked around about the first week in April, and then they slowly decayed. This is the kind of profile time series that we use in our model, age specific, actually, by age and by region. So data started to accumulate, and this is what we use. The other thing that we use is this metrics. Now we had enough information to inform or to estimate the interaction between different age groups. And this is the baseline metrics, the polymont contact metrics, which expresses the average number of contacts between different age groups. This was taken from the literature at the beginning, before the lockdown, and then slowly and progressively modified through information on Google mobility and time use survey, and information on opening and closing schools, school holiday, and the number of students present in schools, to be able to mimic the change that it was happening throughout the lockdown. The other piece of information is the serological sequential survey from blood donors that I mentioned earlier, and at the bottom we have a picture of that over time in different regions. So we use this data from April onwards until the lockdown was slightly eased around about mid-May, to estimate the number of infection and all the related quantities. Next, please. So this basically summarizes what I've just said. We had seven NHS regions, we had 8 age groups, and we estimated region-specific reproduction numbers, number of new infections over time, the proportion of the population infected at any point in time, and then we provide short-term prediction on the number of deaths, age-specific infection fatality ratios, which is the probability of dying given that you've been infected. The model seemed quite simple, but in reality, at this point, it was getting quite complicated, and there were 206 model parameters that needed to be estimated given the data that we had. Please. These are examples of output that we produce over time. So we have infection, the reproduction number over time, and the prediction in the number of deaths. Then vertically in each column, we have the results at different time points from the beginning of the beginning of the relaxation of the lockdown, progressively until almost the end of June, when things were being released, eased progressively. You can see from the infection, and this is for 2 particular regions because it was difficult to portray many regions. For instance, for London and the Northwest, the effect, the impact of the lockdown, which is the black dashed line, it was enormous in London, for instance, with a very, very, very sort of sharp fall in the number of infections, less so perhaps in the Northwest. Then the second column gives you the progression over time of the reproduction number. And you can see that, for instance, in London, there was initially a reproduction number slightly lower than in the Northwest. They had they experienced a big change after the lockdown. Yes, thank you. And the difference probably was due to the fact that in London there were many more imported infections, and in reality, you know, the reproduction number was a bit lower in London. And then going down over that column, you can see that the progressive change over time as data were accruing, were being accrued. Also note that this is a technicality, that we changed the model over time, making the model more flexible, and this is really nicely reflected in the bigger uncertainty, but also in the bigger uncertainty, which then discriminated initially between the two regions very nicely, and allowed us to point out that the things were progressing or were happening a bit different. There was a regional heterogeneity to be looked at, and then we have on the last column the a plot of the fit of the model to the dense, which was very good, and the predictions, the short-term predictions. The dashed line represent, the black one represents the lockdown, and the other two when the data were analyzed. Okay, next please. Okay, so very interesting measure of whether transmission was ongoing or not is the probability that the RT is bigger than 1. And this was one of the outputs of our model, and I'm going to show you here the progression of this probability for different NHS regions. I don't know whether you can see the color or the name of the regions. I mean, the font is pretty small, but this is what was happening, for instance, on on May the 10th, where the social restrictions were going to be were being eased to start with, and then you can see that the probability, I mean, the way the model worked, which was to allow a transmission before the lockdown and a different transmission after the lockdown, resulting in the fact that, you know, we eliminating transmission. The probability of RT bigger than 1 was basically 0 in all the regions. As we made the model more flexible, and as from the previous slides, then different patterns started to appear. For instance, it wasn't so obvious that at the beginning there was this drop, and the probability of RT bigger than 0, bigger than 1 was 0 everywhere. There was actually a heterogeneity that came up in the various regions. At this point, we were able to identify different levels of probability for the different regions. And then this was going on. This was an analysis done at the beginning of June. And note the Northwest had a probability that RT was R was bigger than 1 at that point. And I think this creating creating a lot of interest and some consequences from a pandemic management point of view. Please. The same characteristics were estimated as we accrued data with this probability changing over time as we were observing, accumulating data. And the last one is on the 10th of June. Please, next. Okay, so what was the impact of our work? I mean, there are some things we can measure. We provided regular, initially 3 times a week, and then weekly in the most recent months, contribution to SPI-M, the modeling subgroup of SAGE. Then our results have been used by the Joint Biosecurity Center and by the regional PHE teams to describe the regional epidemic. And this was in terms of estimating R and not estimating new infections, and importantly, allow the identification of important heterogeneity across age and region. Another impact, please next, was the regular publication on the MRC BSU website, which was followed by many, and as I said earlier, informed the regional pandemic management, for instance, no reopening schools in Manchester at the beginning of June. First, next, well, then scientific publications. So we have things which are on meta-carbon preparation. One of the characteristics of this really with this period and participating in the pandemic response meant that lots of the groups really didn't have the time to produce scientific publication, publish scientific work in high level, high impact factor journals. So like us, lots of people are still waiting to have their papers published. And last, we had a nice official recognition as a letter to our Vice Chancellor in Cambridge for the work we were doing to help the government, with a plea of allowing us to continue to do the work. Next. Now, during the summer, the landscape changed a little bit from the emphasis on R and on regional and national pandemic. The focus, the emphasis was moved to localized outbreaks. So this is a picture, for instance, of the work done at PHE to identify exceedances. And Claire, if you can indicate, I mean, the black dot represent the number of positive cases per 100 tests. And then when they become red or orange, they indicate exceedances. And exceedances is defined as going beyond a threshold, which is here described by this red line. So there was an awful lot of that during the summer, with lots of little localized outbreaks, which then in some situations, like in Leicester, resulting in local lockdown. Please, next. So at the end of, I wouldn't say the summer, but the end of August, we were estimated the RT was around 1 in almost each region in England. We estimated that the attack rate or the cumulative infection was 8%. So 8% of the population in England had been at that point infected, 16% in London, 10% in the Northwest. And the infection levels at that point was low, at 2,800 per day, consistent with estimates of the number of new infection per day from other surveys, like the Zoe Symptom Track app, which was estimating, which is based on self-reporting of symptoms and follow-up testing, which was estimating 1,980 new cases per day, and the ONS community survey with repeat swapping or representative samples selected in a household, which was indicated 2,200 new cases per day. Next, please. That was the end of August. Now, in the last 2 weeks, you've seen that there has been, at least in the last 2 weeks, there's been a resurgence in European countries. And they are typically, or they've been historically, ahead of the UK by 2 weeks. Now, what are we looking at? Here is signs of increased transmission, and there are quite a few at the moment. The first one is the pillar 2 testing. Remember, the pillar 2 test is in principle the testing through the community, from the community. So it's an indicator of the transmission within the community. And this is at the moment is showing increase in the number positive and then proportion positive. And initially just in younger age groups, but now in all adults and in most regions. Next. The ONS and the ZOAP are declaring an increase in infection. I think today the ONS will publish the new estimates, but this was the one relevant to the most recent week. And from 2,200, which I mentioned in the previous slides, is gone to 3,200, and I'm sure today there'll be a further increase. And then the ZOAP from 1,980 to 3,800, and I think I've seen already an increase somewhere. Then both the ONS and the REACT study, the REACT study is another sort of Imperial College-led prevalence study. You must have heard of it, are declaring increase in COVID prevalence. So the number of people that have the virus in the population, and then an increasing number of regions are reporting multiple local authorities experiencing outbreaks. So in conclusion, there are signs that, please next, there is no longer, we can't really talk anymore about endemic disease in the country with occasional outbreaks, which was the picture during the summer, but there is the beginning of an exponential resurgence. So what are we going to do, or what are we doing about this at the moment? So it's clear that deaths, which was the main data stream that we were using, are not currently appropriately a strong signal anymore. First of all, because they're not increasing, they've been decreasing over the summer, now gently plateauing, but not showing any signal of increase, because remember, these are lagged indicator, and also the government has changed the definition of a COVID death, so we need to revise some of the work that we've been doing in the past. Please, next. Then there is a change in infection fatality ratio, so the probability of dying as from evidence from hospitalized patients is changing. There has been a big decrease in mortality for COVID in hospitalized patients from the beginning of April, where there was 35% mortality, to half of that, more or less, at the beginning of July. So we need to change our model to account for that. Most importantly is to incorporate the pillar 2 testing data to supplement the death data, because the testing data are much prompt measure of the ongoing transmission. They're not lagged. So are the estimates from community prevalence surveys. So there is work ongoing to do that. Then there are lots of others. There are lots of other issues which we haven't addressed, which is the interpretation of the seroprevalence as an imperfect marker of cumulative infections, because we are observing that the proportion, the serological data is showing decrease over time. So we wonder whether there are waning antibodies, but there is no an answer to that. And also the model is losing the capacity for real-time inferences data accumulate. So we need to spend some time to develop a more efficient, computationally efficient approach to estimation of this model, which is becoming quite complex. Okay, but the priority now is to introduce a change in the mortality rate, and particularly incorporate the pillar 2 testing data to supplement the death data. We've had a few stab at it, and there are quite surprising results, which we need to validate a little bit longer before making them public, but the direction of travel is still the same as everything else. There is a potential exponential growth again. So watch this space. So we'll update our website as soon as we're confident about the use of this data, which are proving very, very challenging for a number of reasons, ascertainment, changing over time, threshold in capacity, which are making this data difficult to interpret. I think I'll finish now. Sorry for taking too long, by acknowledging all my collaborators in the MRC Biostatistics Unit, Paul Binder, Josh. Paul is the main person who's working on this project. Josh is a PhD student that started in October, who to improve pandemic models, and he ended up actually working on a real pandemic. And Pretzanis, who works on severity, and then all the colleagues in Public Health England. Edwin, who's the expert on matrices, content matrices. Nick Gent, who is a doctor who knows everything about everything. Andre is the other statistician working with us, head of the stats unit at Public Health England. And then acknowledge the MRC support through the core quinquennial funding, and hopefully surely we'll put some updates on our website soon. Thank you very much for your attention and questions.